you guys. Today's topic is one that's very important to me for several reasons. One is because both of my parents, who are now older, my father's now deceased, were type 2 diabetics, which significantly increases my risk for becoming diabetic over time. And then as recent as this past April, I actually lost a 39-year-old niece to complications of uncontrolled diabetes and hypertension. So management and how you care about your diabetes, first of all, getting recognized that you have it and then taking care of managing the disease is very important. So let's start with just a definition. What is diabetes? Diabetes is simply defined as the inability to control and utilize sugars. And another word for sugars is carbohydrates. And so food is converted into sugars or carbohydrates by the digestive process. And insulin is secreted by the pancreas, which is an organ on the left side of your upper belly. And the insulin is used to enable sugar to enter the cells and to leave the bloodstream. Now, if sugar can't enter the cells, it remains in the bloodstream. And that's why we check blood sugar levels to determine whether or not someone is diabetic or not. And we also use those sugar levels to tell us how well controlled a person's diabetes is. So diabetes is one of two different causes, or a combination of two different causes. One is insulin deficiency, in which case the person doesn't make enough insulin to control their blood sugar levels. The second cause is insulin resistance, and that means that the insulin that the person makes is still not effectively functioning like it should normally. And then the most common causes in type 2 is a combination of both insulin deficiency and insulin resistance. So how do you know if you have diabetes? And this is a tough question because many people who have diabetes don't even know they have it. Early on in the course of the disease, you may not have any symptoms at all. And usually we diagnose it by screening fasting blood sugars. A person goes and gets a physical with their doctor, or they have a physical on the job, or they just happen to test their blood sugar at a health fair, or a loved one's glucometer to test their blood sugar. A normal blood sugar that's fasting before you eat, or 8 hours without eating, is less than 100. Now we have a category between 100 and 125 that we call pre-diabetes. That's an important category to remember because the people whose fasting blood sugar is in that range are at risk for becoming diabetic. And then if you have a fasting blood sugar greater than 126, we'll be very worried about that person being diabetic. In order to make a definitive diagnosis of diabetes, you need two different blood sugars at least 2 weeks apart that are greater than 126. Now, if you have a blood sugar that's really high, greater than 300, the first time you do it and you're fasting, we already know that that person is diabetic. One of the other labs that we use to diagnose and also follow the management of diabetes is something called a hemoglobin A1C. That test is actually what percentage of your red blood cells have sugar attached. And that will tell us also whether or not a person is or isn't diabetic, and also will tell us how well that diabetes is managed. So early in the course, you may not have symptoms at all, but late in the course, you may notice some symptoms: increased urination, increased thirst, increased appetite, weight loss, fatigue, and blurry vision. These are all side effects of being sugar toxic. And what that means is that your body is not able to take sugar out of the bloodstream to use for energy. As a result, your body tries to get rid of that glucose by peeing it out. And when you urinate more, you become dehydrated. That increases your thirst. Also, we talked about not being able to use the sugar that you take out of the bloodstream for energy and also for functioning. And when that happens, you become hungry. And although the diabetics are eating and drinking more, you're actually losing weight because you cannot use those calories, because you're not getting the signal from the insulin to pull those calories out of the bloodstream to use for energy. Those people also fatigue, and even the fluid in the eyes between the actual lens and the front of the eye has sugar floating around in it, and that makes your vision blurry. Now, there's two different types of diabetes, two different general categories. There's type 1 diabetes and type 2 diabetes. Type 1 diabetes is about 10% of the diabetics. And those are the old term we used to use for type 1 diabetics is juvenile onset. We don't use that term as much now because we're seeing more and more people being diagnosed with type 1 diabetes, even in their adolescence and even as adults, what we call late onset presentations of type 1 diabetes. And what type 1 diabetes is pure insulin deficiency. We mentioned earlier that one of the causes of diabetes could be just the fact that you don't make enough insulin. Type 1 diabetics don't make enough insulin. Usually that's caused by autoimmune destruction of the pancreatic cells that make insulin. And sometimes we usually catch that early in life, sometimes in adolescence, sometimes you'll catch it a little bit later into early adulthood. That type of diabetes can only be treated with insulin shots or a pump. And the reason why is because the problem is not that the patient's insulin is not working right or that it's resistant. The problem is they don't make insulin. So we have to replace the insulin that they don't make to control the diabetes. Now, type 2 diabetics make up about 90% of the diabetics, and that type of diabetes was formerly called adult onset diabetes. Usually that's due to a combination of insulin resistance, and when people become type 2 diabetics, they also have a little bit of a problem with not secreting enough insulin as well. Usually it's a combination. It's more related to obesity, family history, and then certain racial predispositions. African Americans, Hispanics, Native Americans, and Asian Pacific Islanders all have a genetic predisposition to become diabetics. And as far as family history, it's always important to know your mother and father's diabetic history as well as your direct family members. If your mother or father has diabetes, that increases your risk for becoming diabetic. Now, treatment for type 2 diabetes, one of the big things that we underemphasize, I think, in medicine and across the board is good, healthy lifestyles. And what I mean by that is weight loss, diet, and exercising. It's crucial to anybody that's diabetic as far as the long-term management of your disease and also for a quality of life. We also treat diabetic patients with oral medications, and they work by a myriad of mechanisms. Some of them reduce insulin resistance, like metformin. Some of the medicines you can take will increase your insulin secretion, or what we call secretagogues like glyburide or Amaryl. And then we also have some drugs that we use to actually decrease your absorption of sugars. And then ultimately, if you're not able to control your diabetes with oral medicines or lifestyles, we add insulin to the regimen, or we may convert you over to insulin. But that all depends on how well the diabetes is managed. This next slide says something significant. It talks about just chronic diseases. And when you think about diabetes, you have to think of it in the big spectrum of chronic illnesses. Why is diabetes that important? Because usually patients who have diabetes don't have diabetes by itself. They also usually have hypertension, they have high cholesterol. And I call those three things the deadly triad. Many times they don't cause symptoms. They require unpleasant lifestyle changes to actually help manage those chronic illnesses. And medications don't necessarily make you feel better. They improve you over the long period of time, but people who are early in treatment of those chronic illnesses may not notice or feel a big difference, even though the medications may be helping. These medications are expensive, sometimes inconvenient, and then severe complications sometimes takes years to occur. But when they do occur, they usually cause great complications. And so prevention of these chronic illnesses is key. You know, if you have a genetic predisposition, it's important that you know about it early. It's important that you do the lifestyle adjustments that will help prevent you from becoming diabetic, having hypertension, or having high cholesterol, because the burden of the disease over time has great consequences. Another important fact about type 2 diabetes is, along with hypertension and high cholesterol, those illnesses clog up arteries. And anywhere you have arteries, you can have effects of arteries being clogged up, those being in your brain, and if that happens, it can lead to strokes. Those that are in your eyes, if that happens, it can lead to blindness. Diabetes is the #1 cause of blindness in the world. If that occurs in your heart, you can end up having ischemic heart disease and heart attacks. If it happens in your kidneys, you can end up with end-stage renal disease or kidney failure. Diabetes and hypertension, again, #1 and #2 causes of renal failure. And then if that happens in your peripheral arteries, blockage of those peripheral arteries lead to complications and problems with circulation in your legs in particular. Again, as we mentioned, type 2 diabetes is the #1 cause of blindness. It can also cause nerve damage, something we call peripheral neuropathies, where people lose the sensations in their legs and in their fingertips. If you're pregnant and you're diabetic, that brings a whole host of complications to the pregnancy. And many times, a pregnant woman who is diabetic will have to be managed by, a specialist. And then you have a decreased ability to fight off infections. And that's simply because the elevated sugar levels in your blood also affect how your white blood cells respond to infections. So type 2 diabetics are also considered to be immune compromised. So diabetes by the numbers. Why is diabetes such a big deal? 16 million Americans have diabetes. And then another 16 million Americans have prediabetes, which means that they're going to become diabetes. So the prevalence of diabetes has increased about 49% during the 1990s. So what happened during the 1990s? Our country both has benefited from being affluent, but we also have suffered some from being affluent in that we have lots of rich processed foods, high in carbohydrates and high in sugars that we consume. It's easy to get fast food, which contains a lot of carbs and usually are not of great nutritional value. As a result, we become more and more obese, and then we see the prevalence of diabetes skyrocket. 800,000 new cases per year. And then the crazy thing about it is that a third of diabetics don't even know that they have the disease. So it's starting to affect them, even though they don't even know that they are diabetic. So more numbers. Diabetes costs about $32 billion in lost wages per year. Adults with diabetes are out sick on an average of about 8.3 days per year, whereas people who are not diabetic are out sick for about an average of 1.7 days a year. There's a huge difference. Diabetics' average yearly medical expenses are about $10,000 a year, whereas a non-diabetic person yearly spends about $2,700 a year in medical expenses. The total cost of diabetes in the U.S., $98 billion. So how do we prevent this disease? So in patients that are higher risk, in particular obese patients and patients with prediabetes, you have to really focus prevention. Diet and exercise, just enough to result in 5 to 7% of weight reduction, will reduce 58% of new cases of diabetes. So 5 to 7% of your weight loss is not a huge amount of weight loss, but if you lose 5 to 7% of your body weight, it significantly changes and decreases your risk for becoming diabetic. So how do we manage diabetes? We lose weight and exercise. Take your medications, and if you have problems with the medicines, you don't like them, they cause side effects, you need to get and speak with your doctor about it. But it's important that you take your medications and you're compliant. You need to be checking your blood sugar systematically and regularly. And I tell my patients, find a way in which they can log those sugars where they can see them, whether that be a meter that can actually give you a printout that shows your blood sugars over time, or whether you write those down in a log. But it's important that you see the blood sugars because they will help you manage your disease. And then keep your doctor's appointments. On average, we see our diabetics about once every 3 months, and there's a reason for that. If you see patients once every 3 months, you're better equipped to help adjust medications and lifestyle in order to help control the disease. And patients that see the doctors regularly usually have better control of their diabetes, and they have less complications of the diabetes over time. Diabetes is also a multidisciplinary approach to care. And the more people you have looking at and thinking about and taking care of patients from different angles, the more success we have with those patients. At Kelsey and many of the diabetic programs, we have nurse educators, we have dietitians, we have good clinical practice guidelines, and then we have a systematic way of monitoring diabetic control labs like the hemoglobin A1C value that I spoke about earlier. And then when all this fails, the doctors will nag you and see if they can help you control your diabetes over time. I think that concludes our slides. We're going to take some time now to see if we can answer some of your questions. So somebody asked about the cost of diabetes over time. That figure that was on the slide showed that that we actually spend, the U.S. cost, is $98 billion per year. Not 98 million, but $98 billion a year on diabetes. Huge amount of money. Second question asks, is it okay to have desserts after a meal? Well, again, desserts are going to be higher in processed carbohydrates or simple sugars. They're going to make your sugar run high. Now, if you told someone to never have a dessert again, I don't think that that's a, if you totally deprive yourself, I don't think that's a good way to approach overall healthy lifestyle. But you want to limit your amount of desserts that you have simply because you want to decrease the amount of carbohydrates that you're taking in. So it may be something as simple as having a piece of fruit rather than having a fruit pie, or having a piece of fruit a day rather than fruit juice. But you have to try to manage the amount of carbohydrates that you take in. Next question says, I have 2 jobs, and there are many times I have no appetite at all. And with that, they can't take their medicines because they become sick. How do I handle this? Well, many times you might not necessarily be hungry, but as a diabetic, it's an important thing that you eat regularly. At least you're eating your 3 meals, and many times there's snacks in between. You don't necessarily have to have a large meal, but what you need to do is eat meals that are lower in your carbohydrates with good healthy protein, and also good amount of vegetables that won't run your sugar high, but also will help control your hunger and also level your blood sugars out. If you're taking diabetic medicines, those medicines are made to decrease your sugars. If you're not eating and you take those medicines, you will become sick. So the key is to get on a regimen schedule where you eat regularly. And if you are not hungry, you don't have to eat a lot, but you need to eat things that are going to help sustain your blood sugar and also keep you healthy. She mentions also that the medication for diabetes is very expensive, and that definitely is the case. We have good generic medicines that we use for the most part that help us with management. There are newer medicines that are very expensive. There are ones that are cheaper, but it's important that you try to get with your doctor and they try to prescribe good generic medicines that can help you handle your diabetes without running the cost up. But the bottom line is diabetes is an expensive illness to have. The management of it, just like we mentioned earlier, $98 billion a year spent on this disease. It's expensive. The average person, the person that has diabetes, is usually taking somewhere between 10 and 11 medications a day, after you've had it for a while. And that's a lot of drugs, and it's a lot of costs. So the best thing is prevention. If you have it, get with your doctor and find cheaper ways to manage it. Next question says that if you've ever developed nerve damage in your feet, if you're able to lose weight and get your blood sugar in control, will you continue to have nerve damage? That's a very good question. And that's a good question because what we've looked at over time and seen is that nerve damage and actually how bad your diabetic control is not necessarily directly correlated. So some people who don't have really bad diabetes but have had it for a while develop peripheral neuropathies. And some people who have really bad diabetes never develop peripheral neuropathies. But what happens when a person develops a peripheral neuropathy means that over time the diabetes has damaged the coating of the nerves. And even with weight loss, diet, and exercise, you will better control the diabetes. You may not be able to necessarily reverse all of the nerve damage that's occurred because of the neuropathy. But definitely, if you control your diabetes, the goal is to not have further complications from your diabetes. Nerve damage is a peculiar thing, though, because studies have shown it doesn't necessarily always correlate with your blood sugar control. Next question asks, when should you be referred to endocrine, and why are patients not managed with insulin as much? Well, good question. I think when a person sees the primary care physicians at Kelsey are really good about managing diabetes. And I refer patients to endocrine for one or two reasons. Either that patient is in really bad control and I'm having difficulty even with all the medicines that I'm throwing at them, getting them under control, or I have a patient that has a lot of problems with compliance and would need some help from the diabetic specialist. Not only that, also the diabetic educator that will come and teach a patient how to eat, how to manage their blood sugars. Usually they help me a lot with that. I will dare to say probably about 90% of my diabetics I manage myself. The vast majority, a good primary care doctor has some training in diabetic care, can take care of it. Now, why are we not using insulin as much? A big reason for why we're not using as much insulin is that we have a lot of other agents that are used to treat diabetics now that actually help us not have to use insulin. The big thing to remember about insulin is this, though. It's not a death sentence. It's not a bad drug. It's one of the drugs we use in our armamentarium of taking care of diabetes. If you need it, you use it. And many times, once we put patients on insulin, the insulin will control the diabetes. It's a matter of how much and which insulin agent you use to get good, steady control. Next question says, if someone has gestational diabetes, can the baby be considered to be diabetic or even the mother? Well, if a mom has gestational diabetes, by definition, she has diabetes at least during that pregnancy. Usually the baby's not diabetic, but what will happen is complications of the diabetes from the mom may complicate the pregnancy. In particular, many times those babies are really big if the mom's blood sugar is not controlled, and those patients usually have to be managed by a specialist at many times, depending on how bad the gestational diabetes is. Next question is hot flashes one of the symptoms of your blood sugar getting high? Really high blood sugars and really low blood sugars can cause a myriad of symptoms, everything from feeling hot and flushed to feeling like you're going to pass out. Again, going back to the other symptoms we mentioned, you could be thirsty, really hungry, urinating a whole lot, fatigue. It can cause a whole myriad of symptoms depending on how high or how low those blood sugars are. So hot flashes are not necessarily one of the pathognomonic symptoms of having high blood sugars, but you can see it. Next question says, my blood sugar ranges are up to 110. I've not been diagnosed with diabetes or pre-diabetes, but if I get a bite or a scratch, it takes a month or so for it to heal, and my vision blurs at times. Are these symptoms of diabetes is the question. Well, the first thing I would say is that you need to get with your doctor and make a definitive diagnosis as to whether or not you're pre-diabetic or not. If your fasting blood sugar is 110, you're greater than 100, and then you would fit into that pre-diabetic category. But healing has a lot to do with other things other than diabetes, how good your immune system is, if there's a scratch or bite, how well your skin condition and health is. So there's many other factors that will go into how fast you heal. The blurry vision could be just something going on with your eyes. And we keep hearing me say over and over, get with your doctor, see your doctor. It's important that you have a primary care doctor because we're able to pick up many of these illnesses when they first appear and to help you decide where you need to go, what we need to do about them. Now, the question is asked here about how about eating food with artificial sugar, stevia, and any long-term complications from eating foods made with them. There's a whole host of artificial sweeteners now. I remember back when I was growing up, you had Sweet and Low, and that was about the extent of it. But now you have anywhere from 5 to 10 different sweeteners in any grocery store that you go to, even to the point where a lot of people don't even use sugar anymore. But you have some of the non-nutritive or non-sugar sweeteners are very good. Stevia happens to be a very good one. It's naturally occurring, doesn't really affect the pancreas and the rest of your body as sugar does as far as making you secrete insulin, and it's a good sugar substitute. So I think some of these agents like stevia are good. They have an aftertaste sometimes, but they're not the greatest as far as sweetness, but they are good substitutes for sugar. And you have to remember that aspartame also has some of the other theoretical side effects with it long term. So it's good to kind of look at these artificial sweeteners, decide which ones are healthier for you, but I can tell you stevia is one of the healthier ones. Next question says, what is the chance of kids becoming diabetic who are born to gestational diabetic mothers? Well, I think that kind of fits into the fold of if the mom continues to be diabetic after the pregnancy, how big the baby is. And that also will feed a whole lot into, in addition to the genes the mom passes on to the baby, as to lifestyle. Are those kids active? What do they eat? Do they maintain a healthy weight, or are they overweight? Many times when you look at type 2 diabetics, we're starting to see those people diagnosed earlier and earlier. But when you really look at it, there is some predisposition as far as the ethnicity, and also some of the hereditary predisposition from the parents. But by far, we're seeing many kids become diabetic really early because they have just really unhealthy lifestyles as far as the foods that they eat, and also inactivity. So this is a good question that is from one of our diabetic educators, is what is a good hemoglobin A1C that would indicate good control? Well, in general, again, the hemoglobin A1C is what percentage of your red blood cells that have sugar on it. And we use this particular test because the red blood cell lives from anywhere from 90 days to 120 days. And so if you can get a guesstimation of what percentage of red blood cells have sugar on it, that tells you pretty much what the diabetic control has been for the last 3 to 4 months. A great number is, for diabetic, is less than 7, and that is less than 7%. And so you say, well, why is that an important number? Because we see that people who have a hemoglobin A1C that's less than 7% over time do not get the complications of diabetes as quickly as people who have hemoglobin A1Cs greater than 7. So many of the national diabetic associations have used 7 as the cutoff as far as whether or not a known diabetic is controlled or uncontrolled. I believe one of the other big diabetic medical associations uses 6.5 as the cutoff. But in general, the goal is to get your patients controlled to where the hemoglobin A1C is less than 7. Now, this is a very good question I get asked often. Once you've lost the required weight and stick to a healthy diet plan, can you be taken off of medicine for diabetes? And that's a great question, because everybody who's diagnosed with diabetes asks that question up front because they don't want to be on medications long term. And what I tell my patients is this: if you're type 2 diabetic, that means that a lot of your diabetes is due to the fact that you have some insulin resistance, and usually that's from being overweight and eating unhealthy things, as well as having some hereditary risk factors. Those people usually can lose weight and come off of some of their medications. But I tell my patients the proof is in the pudding. If you're 400 pounds, you have a lot more weight to lose than someone who is, 220 pounds for the same height. And so it's a process of watching that person lose weight, diet, and exercise, and pull that blood sugar down. The nice thing about it is this: is if you're managing diabetes over time, you can actually watch the blood sugars come down. And I have had patients that were diagnosed that lost some 10% of their body weight, some half of their body weight, because they were 400, 500 pounds, that I've had to take off of the diabetic medicine because they didn't need them anymore. And we were able to see that because their daily blood sugars that they were taking were coming down and getting to the point to where if we didn't take them off the medicine, their blood sugars would run too low. So if you're a type 2 diabetic, most likely there is the possibility that you can come off of your medications. Now, never do that on your own. Work with your doctor, and then let them show you how to come off of your medication over time. Now, the next question is, does keeping your A1C less than 7% guarantee that you won't get the complications of diabetes? And diabetes, like any other disease, chronic illness, it's a continuum. And so you'll have some people who have hemoglobin A1Cs less than 7 that do have some of the complications of diabetes. You have some people whose hemoglobin A1Cs are greater than 7% that don't have complications of the diabetes. And so the answer to that question is no, nothing can guarantee that you won't have complications of the diabetes. But from good studies and great clinical data, we know that people who in general keep their hemoglobin A1Cs less than 7%, they have much less incidence of having the big complications of diabetes, simply because the blood sugar doesn't ravage their organs and blood vessels like it does people who are out of control. And so the A1C of 7 is a goal, but it's not necessarily great. I have some patients that will come in that are newly diagnosed diabetics with a hemoglobin A1C at 6.9 when we first start. Something simple as having them lose weight. Maybe they take metformin. Their A1C comes back down to the normal range, and they're not having low blood sugars. They're living well, eating well, doing well, but we have significantly decreased their chance of having complications of the diabetes, even though their original hemoglobin A1C was less than 7. So again, those are numbers. Numbers give us a guideline. There's something we kind of follow, but each individual's disease and each individual's situation is different. And so that's the art of medicine, is that the doctor is able to see you where you start and then help you get to a goal that is beneficial for your health now and also in the long run. Thank you all so much for listening to me today, and great questions.
All right. A special thank you to Dr. Sims for presenting with us today. Thank you, thank you. Please remember to join us next month. Dr. Anthony Holbert of Clear Lake Medical Center will be talking about cholesterol. So you can go ahead and sign up right now at Kelsey-Seybold.com/webinars to register. And also, I saw a few people asking for a copy of the PowerPoint presentation. You can do that by emailing me. My name is Valerie Clifton, and it's valerie.clifton@Kelsey-Seybold.com. Thank you so much.